Hi, I just wanted to check, based on the answers we've had so far, you do not have an estimate of how many family doctors this will add to the number we have now, and you do not have an estimate of how many patients who do not now have a family doctor will be able to get one as a result of these changes. Is that correct?
I think the answer is yes and no, Vaughn. We know from the changes we've made already that these new arrangements are going to increase the attractiveness of family medicine and of family practice and of full-service family practice. We've seen that already with our new-to-practice contracts. We've seen that in the work we've done with our stabilization fund. So we've seen the impact of that. Secondly, I think that what we see is that, and you don't know exactly how something's going to work, but this is only one part of a number of measures. So this is foundational. This improves and incentivizes family practice and improves things for patients as well by building out team-based care for them. And so I expect this will lead to more people and more doctors practicing for longer, so existing doctors being stabilized in their practices and attracting new people to full-service family practice. So our expectation is that that will significantly increase things, but it is not a one-step response to a broader problem. We have a health human resources plan that has 70 items in it. We need to address residency spaces. This agreement supports that by ensuring that those doctors who are supporting residency programs are properly remunerated, and it allows us to do what we've done, which is expand out residency programs. When you dramatically increase by 128 at UBC the number of spaces, when 92% of those doctors stay in BC, you know that's going to mean more for full-service family practice. So the goal of this agreement, in connection with the actions we're taking on internationally educated doctors, the actions we're taking with respect to training more doctors, and the focus on family practice and equalizing family practice against other kinds of medicines, is going to have a very, very positive effect. We can't be exact. I think that's what you're asking about, what that effect will be, but we know that it will be positive, and it'll provide more care and support our primary care system. So that's the intent, that's the goal. All of the indications show that it is going to significantly improve things. This is an improved investment in that system. And the other part of rostering is it will allow us to more clearly monitor the effects of that on the system. So if you're asking, this agreement, does this mean X number of new patients will be attached to a family doctor? You can't say that and guarantee that for sure, because we will have to see how it happens in practice, but we know for a fact that we'll make things much better, both for patients and for doctors, and it's going to have a positive effect. But we can't just do this. We have to do all of the other things that we're proposing. There are 70 actions in our Health Human Resources plan. We have to do all those things together. So it's building brick by brick in response to this massive period of demand on the healthcare system, a pandemic and the overdose public health emergency. In that context, we have to keep doing that. So this is one important action. It's foundational. We need to do other things as well.
Vaughn, did you have a follow-up?
Yes, please. I'm still trying to understand the new model payment for a full-time FTE, full-service family physician. So the $385,000, is that a max? Because I also think I heard, or I think as I read it, that there's a minimum number of patients you have to see, but there isn't a max. And so if you exceed the basic hours or the number of patients or the number of counters or all three, can you go above that? And is there any ceiling on that?
Well, there are, as you know, if you look at, it's published every year, so everybody knows. There's no secrets in what we pay doctors as individuals or collectively. We know that there are doctors who work very long hours and are very focused on that, and that group of doctors will also be supported by them. So we don't want a situation where someone is committed to doing that for their patients and is restricted in some way from doing that. And so that's the idea. But we're very specific in the new payment model, and we'll go through it because I think we did that in the briefing, Vaughn, but we didn't do it in as great a detail here, is based on providing 1,680 hours work, 1,250 patients of average complexity. So a doctor who might have higher complexity might have fewer than that conceivably, and that's one of the elements of the agreement. 5,000 encounters a year. And what this does is, and as a goal, it equalizes full service family practice against other types of medicine. So you're right, it may be possible if a doctor works well beyond that for them to earn more than that, and that would make sense. But this links the amount doctors get paid to the care they provide. And it's very important, based on the previous question, to understand this. If you're in a fee-for-service system, your economic interests would be supported by having a very average patient base. For not necessarily, and patients sometimes complain about this. They say, I have very complex needs and I'm going to need to see my doctor for a period of time, and I have a difficult time finding a doctor, they might say, for that reason. I think many doctors make allowances for that, and we know that this happens every day in the system. So what we have is a payment model based on the work done and based and focused on care that addresses doctors' issues around overhead. So if you're going to do that, the fee-for-service system says you get a fee for service. You do more services, you get paid more. That system hasn't been working for patients, hasn't been working for doctors for some time. This provides a base structure that says this is the work you do and this is your remuneration. There will be some people who it might work, and you can work as little as 0.2. For example, 1 day per week. And obviously, if you work 0.2, you get paid less. If you want to work more in the system and provide more care, we don't want to limit that, because that's care for patients, and we want patients and all those patients who are both unattached and attached to get the care that they need. So this is the base. It lays out a base, and it provides an alternative. And it is, I would argue, significantly, we would expect very significant number of doctors to take on this new program. And there may be some who stay on fee-for-service, but this is, I think, an arrangement that doctors themselves co-designed, and I think addresses the needs of the system. So what you're talking about, Vaughn, you're quite right. That is the base. You can do more than that if you do more work than the base. And of course, if you're working, say, 0.2 hours, you would a week, you would get paid less than that.